Okay, it's 2:00 where I am, so we're going to get started. Good afternoon and welcome to today's Rural Cultural Competence Training for Transportation and Mobility Professionals. My name is Liz Taylor. I'm the Assistant Director at National RTAP, and I'm very excited about this training today. So I'm going to go through a few introductory slides before we get started. Next slide. So just in case anyone is here who's not familiar with our program, the National Rural Transit Assistance Program is a technical assistance center funded by the Federal Transit Administration through the Section 5311 program for rural areas. We provide no-cost training and technical assistance resources and services, and I'll speak just briefly about them on the next slide. They're aimed at rural and tribal transit providers and state programs, but for the most part, anyone is welcome to use our resources. I guess I should say anyone related to public transportation or transportation. We are guided by a 14-member review board made up of transit agency staff and State Department of Transportation staff. I'm based in Massachusetts at our headquarters, and we also have an office in Washington, D.C. And everything about our program you can find at nationalrtap.org. Next slide. These are the 5 main areas of our program. So we're most well known for our training materials, both hard copy and e-learning. And we also provide training through webinars and at conferences. We have other formats of information. So technical briefs, best practices articles, comprehensive online toolkits, topic guides, and a great e-newsletter coming out tomorrow. We have technology tools for procurement, cost allocation, hosting and building a website, and GTFS to get your routes and schedules on an online trip planner. We have peer networking there through webinars, through peer roundtables, at conferences, and on online forums. And we offer reference services and technical assistance and tech support. If you have a question, reach out and we will help you or connect you with somebody who can answer your question. Next slide. Okay, so I'm really excited to introduce our speakers today, but before I do so, we shared this yesterday with anyone who had registered. This is a pre-evaluation. So if you have not yet done that, please scan this with your phone and submit that. You don't have to, it's just helpful for our presenters. And if you have any questions, type it into the chat. So our speakers today are from the Rural Health Network of South Central New York, whose mission is to advance the health and well-being of rural people and communities. And I got to work with these 2 wonderful women on a grant program, the Community Rides Grant Program, the National RTAP ran in 2021 to just earlier this year. And so I worked with Mary and Emma, and that's how this came about. We learned about this training that they ended up developing as part of their project, and we wanted to share it with others. So while you guys are hopefully doing the pre-evaluation, I'll just share a little bit more about Mary and Emma. So Mary is the Director of Community Health at the Rural Health Network of South Central New York. She oversees a team of community health workers and educators, AmeriCorps members and interns, whose mission is to provide health access and education to rural people in the South Central New York region. She is a certified instructor for the evidence-based mental health first aid course and a master trainer and peer leader for the evidence-based chronic disease and chronic pain self-management programs. She has developed and delivers several professional development trainings for those working in rural communities, including rural cultural competence, social determinants of health, health literacy, and self-advocacy. Mary holds a master's in public administration. And Emma is the Assistant Director of Community Health. She implements data management processes and evaluations that demonstrate the impact of social needs interventions. She supervises the Northern Broome Cares, a state-funded program for older adults in rural Broome County, New York. And the Rural Health Network, as again, was a grantee of our Community Rides program. Emma holds a master's in public health. So final thing before we get started is a quick poll about what sector you are representing today. So if you can complete the poll, and we'll share the results, and then Mary will get into the training. Okay. Give it just a few more, little bit. We're at 66 participating. One more minute. All right, I'm going to end the poll and share the results. So hopefully you can all see that. And so, you know, makes sense. Our audience is mostly transportation providers at any of these levels, but also community-based programs in public health. It's great to see everybody here today. So I'm going to stop sharing, and Mary, I'm going to turn it over to you.
Thanks. Oops, there we go. Thanks, Liz, for that kind introduction. Emma and I are excited to be here today. We had to take a little bit of a break from all of our sort of professional development kind of trainings during COVID, when, you know, everybody's lives got topsy-turvy. And so we're really glad that more opportunities to present this information and to share with folks are presenting themselves. I will say this is the first time we have done this training with this many states across the country being represented. Typically, it's folks in our own region or across New York State who are participating in this training. So really exciting to see the registration list that Liz shared with us, and to see all of the different folks that are represented. We did know that the vast majority of you were from federal or state or local excuse me, transportation programs. And I saw from the poll responses that there's some crossover with community-based organizations there as well. So that's great too. Keeping in mind that this training is pretty broad. This training is not specific to transportation programs. This is the purpose of this, excuse me, the purpose of this is really to highlight disparity between rural and urban sort of causes and effects of, you know, circumstances that people might be dealing with, and just to show the difference between the need for services and the services that people receive. So we're not going to zero in too much today on transportation need, but we do talk about it a little bit when we get into discussing particularly healthcare access issues. So moving ahead, I just wanted to talk a little bit about our organization. So we are located in the southern tier of New York State. So the population center that is probably most well known is Binghamton, which is a small city, right, sort of in the lower middle of our region. We do serve up to 10 counties, depending on which of our departments you're looking at. Just to very, very briefly share what each of those departments do. So Emma and I are from the community health program, which Liz described to you in our bios. As she mentioned, we do have about 16 people. I just updated our program sort of structure today, and we've got about 16 people, which is actually about half of our organization. So we're a relatively small organization, and most of those folks are part of our program with Emma and I. Our Get There program is our mobility management program. They do a variety of things. They have call center, they have mobility transportation advocates who do call center type work. So when people need non-emergency medical transportation, our call center folks will work with them to better understand the resources that are available to them in their community and figure out ways to help them get where they need to be. They also do some travel training and some transportation to employment programming, which is pretty cool. Our Food and Health Network program is a healthy food access program that focuses on both policy and advocacy for healthy food access, but also does some really interesting work around fruit and vegetable prescription programs in partnership with local clinical providers, and like some farm to school and farm to institution projects that are a lot of fun. Our Rural Health Service Corps is our AmeriCorps program. So we are an upstate New York hub for Public Health AmeriCorps and AmeriCorps Vista. And so on any given year, we filter through probably 20 to 30 AmeriCorps members. Some of them stay right here with us at Rural Health Network, but the vast majority of them are working with our community partners across our region on a variety of health-related projects. And then rural health planning is really working with local hospital systems, county and regional health departments, and other groups who can benefit from some capacity and support to do like data collection and health improvement planning and those types of things. And so those are projects that we will help with as well. And you can see, again, you can see our region there on the map. So talking about cultural competence, what we have here on the slide are really two definitions that are both accurate, and they're essentially saying very similar things, but they're coming from different perspectives. So that first definition that you see there, that longer one, really applies more to organizational or programmatic cultural competence. And one of the things that we will talk about today is ways and strategies to build cultural competence within your program, within your organization, within your sector, or within your system. And then that second one, that second definition there is really individual cultural competence. So that's really taking a really self-aware look at how culturally competent or culturally sensitive am I as an individual. And the reason that it's important to understand and sort of pay attention to both of those definitions is that when we're working with, whether it's individuals or communities or identified populations, it's important to remember that the attitudes that we adopt influence the way that we interact with individuals and also the way that they interact with us. And so if I am a person who is not very culturally sensitive in my own life, but I'm working within an organization or a program that is, that's going to cause some disruption in my ability to do my job. At the same time, if I am a person who is very culturally sensitive, very culturally competent, but I'm working within a program that is not paying attention to their standards, policies, and practices in terms of increasing their cultural competence in their programs and the way that they deliver their services, then again, that's going to cause a lot of conflict for me because I'm going to be working within a system that doesn't align with my values. And so it's really important as we're looking at the services that we provide, the people that we're interacting with, the interventions that we might be developing, to think about cultural competence from both of those perspectives. So mental models were, when we were developing this training, mental models was a relatively new concept to me in this context. And I find that when we do these trainings and we have these conversations about mental models, it's sort of new conceptually to most of the people that participate in this. I think an easier way to think about mental models is implicit bias, which is something that most of us are much more familiar with, and we can give examples of that, and we know what we mean when we say implicit bias. But mental models take it a step further than implicit bias. Similar to implicit bias, mental models are deeply held internal images of how the world works. However, mental models, like I said, they take things a step further and they push us to look for validation of our beliefs. And it doesn't really take much for that to happen. You know, we might enter a situation, whether it's with an individual or working with a group of people, and we might enter that going like, you know, this is my day-to-day work. I've been down this road before. I know what's going to come of this. I know what I can expect. This is going to work just like it always does. And all it will take is a very small thing for me to go, yep, I knew this was how that was going to go. That's my mental model at work. That's my mental model validating that my belief was correct. The challenge comes when that one little thing that validates me doesn't happen, because that can really throw us off. We interpret situations based on what we believe, right? So that little, you know, the little image here, which I wish I could take credit for, but I cannot, but I think it's brilliant. So I wish I could say I created it, you know, but it, you know, it shows this individual sort of with these goggles on, looking backwards into his own head. And he says, everything you look for and all that you perceive as a way of proving whatever you believe. And that's really what mental models are telling us. What we're looking for is validation to say, yep, what you believe is correct. So I have a video, but I have a feeling it's not going to work, because no matter how many times I test it, when I get to present, they don't work when I'm sharing my screen. So I am going to very quickly and smoothly flip us over to YouTube and share my screen again. So that we can see the video.
Mental models are the sort of we understand the world. It's basically these beliefs and values and ideas that we hold in really deeply, and we don't necessarily articulate those all the time, right? We're just operating on them. We're making decisions based on them. We're approaching our work based on them. Part of what we're trying to do in Reason is to try and surface some of those mental models that are perpetuating racial disparities, and really talk about them in a way that people don't usually talk about them.
I don't change anyone's heart or mind. They do it themselves. So I let go of that to begin with, that I'm going to go out and change somebody. What I do is I go out and I offer people information and a new way of seeing things. If they choose to accept it, they will change their own mental models. It's not about making someone believe what you believe. That would be nothing more than my acquiescing. What you want is for them to see that what they're looking at, that there are other views, and those views are just as valid. And in seeing all of the new data, the reason we get to that point is that we begin to close off, and so we don't see all of the other data that's out here. We only see the data that my data is the only real data, right? So I don't see all of this other stuff. So the idea is to give people space and place where they can see my data, your data, everybody else's data, and go, uh-oh, maybe my mental model isn't quite so right. Maybe I need to go back and check this. The research around what happens when your core values, your mental model gets challenged, that it is the same as being slapped in the back of the head. It's like amygdala hijacking, only about your core values. Mm-hmm. And so we do the same thing, fight, flight, freeze. The rest of our brain freezes.
Once you have that mental model in place for that belief, even if you hear data that disagrees with it, you're like, I don't think that makes sense.
My data is the only true data.
Right, right.
What ends up happening is that as we select the data and we build our beliefs determine what data we actually select. Yeah. And so we have a tendency then to narrow our frame, our scope.
I think there's this way that, especially when mental models they're part of the dominant culture, so they're very normalized, and they've been passed down like generation after generation, that it's hard for people to even question it. So I think that's one of the things I have found as an antidote, is not necessarily to like introduce even something different, but just to say, is this really working for us? It doesn't feel to me like it's working for us.
Yeah.
When our mental models get so cemented, we aren't learning new things. We aren't taking in new perspectives or new ideas. And it's like even just encouraging people to be in a space of learning and exploration, I think can be powerful.
Okay, so those folks described mental models much more eloquently than I ever can.
Mary,
Yeah,
you're gonna want to switch your display settings. We see the, like the slide and the notes, you know what I mean?
okay, hold on.
The fun of switching screens.
Mhm. Okay, how about now, Liz?
Yeah, that looks good.
That's good, okay. Okay, so, yeah, so you want to consider, based on this conversation about mental models, the preconceived notions that we might have about any given population of people, and we all have them, right? We all go through it. We don't even realize we have them. We go about our day making decisions about people very quickly. It's the first thing that we do when we meet a new person or we walk into a new group of people. We all size each other up very, very quickly without even realizing that we're doing that. That same thing applies as we learn about populations of people. We take the information that's available to us most immediately and we make our decisions very quickly about what our interactions are going to be like, how they're going to respond to us, the best way to approach people. We figure that out really quickly. One of the things that we're going to look at in just a bit is briefly some data. We're going to move through some data pretty quickly. Now, I'm aware that everybody here, all 78 of you that are here, probably spend a large percentage of your time looking at data, talking about data, considering what to do with data, making plans based on data that you have. But one of the things that we don't spend as much time doing is thinking about how that data, that aggregation of numbers, influences the way that we think about our target populations and how that data influences the interventions that we develop, the programs that we fund, the programs that we implement, the projects that we think of. I'm willing to bet we don't often ask ourselves, are we working on ways to learn from the people that are most affected by the challenging situations that data illustrates for us? Are we creating new programs and projects and interventions based on what the numbers tell us, combined with what our perceptions of what people need, of what we think that people need? Are we actually taking into account that sort of story behind the numbers? Remember that mental models work both ways, right? So if we are going into situations or meeting new people or planning out activities, our preconceived beliefs influence our approach when we're working with those folks. And so at the same time, those folks have mental models about us as well. Those have been influenced, just like our mental models were, those have been influenced by previous experiences that started a long, long time before they met us. And so as we are thinking about our approach, it's also important to think about how their past experiences or their preconceived beliefs might drive them to respond to us and either accept or not accept what we're offering to them. Can anyone who's here today just unmute themselves and tell me what they think is wrong with this image in terms of acquiring new skills or really learning in general? Can anybody tell me what's wrong with this image on the screen?
These things are not typically linear. They happen simultaneously and go back and forth.
Right, that's exactly right, Jessica. Thank you. So this image is a really oversimplified version of what learning looks like. It also applies to acquiring cultural competence. When we consider the process of becoming more culturally competent or increasing our cultural competence, it isn't enough to simply know and then think that we understand enough to become functional, because as Jessica said, a learning process is not linear. And so what you see here is a more detailed way to show the steps toward building cultural competence. So as you can see, cultural competence is a cycle. We might learn the basics of a given culture, but just like anything, what we think we know is really only the tip of the iceberg. And when that happens, we have to kind of revisit the cycle and incorporate new knowledge. An important thing to remember about a cycle like this is that it goes both ways. So you can see that the little arrows have points on both sides. So you can enter this cycle at any point. You don't have to assume that there's, sort of a natural starting point, and you don't have to assume that you know nothing. You might recognize, for example, that you're already sensitive to alienating behaviors in a particular culture or with a particular group of people. And if that's the case, you might ask yourself how you can change your decision-making processes to better include the people that you're serving. Another example from an organization or a programmatic or a systemic perspective would be you might already have policies in place to support the cultural diversity of the people that you serve, right? And so your next step is to evaluate those policies and make adjustments as you go along. And again, this is not something that you look at once, you go around the sort of circle here and you're like, yep, we're done, we're there. This is something that you can revisit over and over again. So why is cultural competence important? And you can see, the many bullet points here on this slide, but really what it comes down to is being a more culturally competent organization is going to make the work that we do more efficient. It's going to do that by increasing respect and trust between us and the people that we serve. Being more culturally competent promotes inclusion of the people that we serve. It improves client data collection. It increases cost savings because we're not having to go back and do a lot of work over again. Being more culturally competent means we're more culturally sensitive, and people are going to be more likely to reach out to us and turn to us when they need our services. And then from a business perspective, really is about the bottom line. We work for a nonprofit organization, and there's certainly a myth out there that nonprofit organizations don't have to bring in revenue, and but we do have to keep the lights on, and we do have to have community partners in our region who want to work with us. If we're not a culturally competent organization, what's going to happen pretty quickly is that nobody's going to want to work with us. Nobody's going to want to partner with us. Nobody's going to want to fund us. And so that's not to say that our organization is, at the top of the heap in terms of cultural competence, but it is something that we consistently work on. And when we realize that we're misstepping, we do go back and start evaluating things and figure out how we can do things better. And typically when we realize we're misstepping, it's because somebody points it out to us, whether that's a client that's in our population that we're serving, or a community partner, or a funder. Of course, operating with cultural competence is essential for any of us, no matter what population that we're serving. And again, you know, one of the most important outcomes is that we're going to lower costs. We're going to see fewer care disparities in the people that we're serving, and ultimately the folks that we're serving are going to benefit the most. So that was the most high level, quick, very basic overview of cultural competence. The purpose of this training is to focus on rural culture. And so as I mentioned, we're going to get into some data. And one point that I always think it's important to make is this training is not intended to portray rural life in a negative light. We are going to discuss some of the very significant health disparities facing rural people, rural families, rural communities, and impacting specifically health outcomes. But we're also going to talk about strengths associated with rural life. One thing that I would like to ask everybody to think about as we kind of talk about rural culture and you take a look at the data examples that we will share is think about our mental models, right? Think about how this information might influence the people that we're serving or the people that we're developing programs for. And one of the things that we'll talk about kind of at the end, we're going to do some activities today, is thinking about how we might need to change our approach once we learn a little bit more about people. So why do we focus on rural? So we recognize rural residents and communities as a culture in their own. So we don't often think about rural people as their own culture, but they absolutely are. And something that's been pointed out to me several times in doing this training with people who are really familiar with rural communities in the audience, they tell me, or they remind me about the culture within the culture. And that's true of any culture. It's very difficult to make broad, generalized statements about a population of people or a culture. But there are absolutely going to be pockets of other cultures within a larger culture. Rural residents often face determinants of health that might be unique and contribute to more significant health disparities. And those disparities can lead to attitudes, perceptions, and beliefs, both on the part of those living in rural areas and the providers that serve them. So again, those mental models. The Federal Highway Administration reported in 2017 that rural America comprises 83% of the nation's land, 21% of its population, so about 50 million people, and 18% of jobs, but only 14% of earnings. And in the United States, 2,300 out of approximately 3,000 counties are considered rural. It can be challenging to narrowly define the definition of rural. There are actually many definitions that exist, as many of you here today probably know. So for example, in practice, the U.S. Department of Transportation defines rural in two ways. First, for highway functional classification and outdoor advertising regulations, rural is considered anything outside of an area with a population of 5,000. But for planning purposes, rural is considered to be areas outside of metropolitan areas of 50,000 or greater in population. So that definition leaves a lot of room for significant differences within those categories. It's also important to remember that other state and federal regulatory offices follow different guidelines. So for example, the U.S. Department of Agriculture defines rural quite differently. It's also important to remember that rural looks different in many parts of the country. I think that probably goes without saying. But what's rural for us in upstate New York is not the same as what is rural in the center of Montana or in southern Arizona, for example. Rural looks very different in different parts of the country, and even in different parts of, I'll speak for us in New York, even in different parts of New York, what qualifies as rural can look quite different. The one thing that all of us have in common, though, are determinants of health. So we're going to spend just a little bit of time talking about the determinants of health, and I will pass it over to Emma to do that.
Thanks, Mary, and good afternoon, everybody. So you may be familiar with this concept of social determinants of health already, but for those of you who are not, these are the circumstances that all of us have. It's the factors in our lives that contribute to our health outcomes. So we know that health is influenced by a lot of factors, and generally under this framework of social determinants of health, they're organized into the 5 very broad categories that you're seeing right here. So education, healthcare, your neighborhood, social and community context, and economic stability. Next slide, please. Okay. So this is more of an individual view of the impact of these factors on a single person. So only about 20% of a person's health can be attributed to the healthcare that they receive through the medical system. 30% of the health outcomes depend upon our behavior, which is often influenced by our surroundings. And then the rest are community factors. So altogether, about 80% of our health comes from these non-clinical, non-medical factors. And half of our health outcomes can then be traced back to our zip codes. So as we're interacting with the people we serve, it's important to consider not only the health outcomes that we're seeing, but the causes. So is there something significant about their circumstance or their community that is shaping their health? Next slide. So here are some examples of rural determinants, and these we compiled based on our experience here in New York. And you can see how some of these impact people's health for the better and some have a negative effect. Some determinants might have positive and negative effects. Some of these are just purely neutral. And these types of determinants and the variation in the quality of the types of care and services that people receive then lead to health disparities, which we'll talk about more so in the following slides. But I just want to take a second to look through what some of the determinants that we are taking into consideration are. So obviously, by definition, there's greater distance between services for people in rural areas, low population density. We see a lot of natural resources. In our area, rural areas have a higher veteran population, lower average income. The population is aging quickly over time, more racially homogeneous, and similar poverty and unemployment rates to metropolitan New York. Next slide, please. Okay, so health disparities. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health. And these are often experienced by socially disadvantaged populations. So listed on this slide are some factors that might put a population at risk for a health disparity. We are likely to see more than one factor at play in any given situation. So someone might live in a rural area, they might experience disparities related to that, but there might also be, for example, a mental health concern. They might have a disability, they might be a racial minority within their rural community. And in this way, we can see how these factors begin to stack up and cause more significant challenges as time goes on. An important point about health disparities is that they are preventable. So many disparities stem from identifiable policy options that have been chosen and voted on and implemented, such as tax policy, the regulation of business and labor, welfare benefits and healthcare funding. So what is important about knowing that they are preventable is that they could then be improved by policy interventions like the ones that I have just listed. So we're going to take a look on the next few slides at some health disparities for rural people. And I'm going to go kind of fast because I am sure that all of you here who are interested in working with rural communities and who work in rural communities yourselves have already seen a lot of this information. But I do want to just present it and make sure that we are all sort of on the same page and thinking about what the data is and how that data impacts our mental models. So next slide, please. We're going to start with some information related to behavioral health, which includes mental health and substance use. For these sensitive topics, culture and stigma often prevent people from seeking help. Next slide. Okay, so rural areas often experience higher rates of behavioral health conditions, but at the same time have fewer resources to address them. So in the case, so these are 3 counties that are in our region. So Delaware County, which is very rural, Tioga County, and Broome County. In Delaware County in particular, they have close to double the death rate due to suicide compared to Broome. But also you can see in the chart on the right that they have just a fraction of the mental health providers to combat that issue available. And then I just want to note here, so Tioga County is really interesting because they are quite rural and they have a low number of providers, but we like to point out when we look at these slides that many residents of Tioga County commute to neighboring Tompkins and Broome counties for work and services, whereas the ability for folks to commute to another county for services out of a place like Delaware County is much more difficult. So that transportation is also a factor in looking at this ratio of health providers and its connection to these rates of higher behavioral health conditions. All right, next slide, please. Here's some information related to substance use. So we talk here about the availability of behavioral health and detox services. The range of services can be limited for rural people. It can be difficult to get treatment without traveling long distances. I also want to mention on that note that it can also be difficult to transport people across county lines with the different types of funding that are available for mobility management programs. I'm sure many of you can relate to that. Rural first responders and rural emergency department staff might have limited experience in providing care. There's a lot of emergency medical services that are staffed by volunteers. And while they do a great job, they're often understaffed. And then, of course, we mentioned earlier, there's stigma related to topics in the behavioral health space. And we'll talk more about stigma when we get into the culture section. Next slide, please. Okay, next up is chronic conditions. So you're going to see a series of charts about the heavier burden of chronic conditions in sort of non-metro, which is the classification for rural in these charts, and versus metro. And this is a combination of all the counties across the nation. So people in rural areas tend to have more chronic health conditions and more co-occurring chronic health conditions, so having more than one. And I will note that a lot of the data that I'll be showing you, like I said, will probably not come as a surprise. And while a lot of the data that I will show you showing trends stops before some of the more recent years, we know that these trends and disparities have continued even to now. These are ongoing challenges that our communities are working with. So the next slide shows excess deaths. So excess mortality, if you could change the slide. Okay, so excess mortality is measured as the difference between the reported number of deaths in a given time period and an estimate of the expected deaths for that period. So we're looking at deaths that we would not have expected in these communities. So for this one shows heart disease. So we've got higher excess deaths in non-metro versus metro. The next slide is the same information, but for cancer. And then I think there's one more. So this is diagnosed diabetes prevalence. So you can see the sort of higher numbers as well as quickly rising rates in the non-metropolitan, which is that darker colored line, versus the metropolitan areas. And I think there might be one more. Obesity prevalence. Okay, the same situation. We're seeing both a trend upward as well as some sort of sharp increases that we're not seeing in the metropolitan areas. Okay, The next section of the data that I want to cover is about access to healthcare in rural areas. So take a look at this chart here, which is the providers per 10,000 people for the metro versus non-metro. So the metro is in gray and the non-metro or the rural is in green. And it's important to note that this has been scaled to population. So it's not just that there are more physicians in a metro area because there's more people there. It's actually, when you look at the ratio of providers per population, there's a much higher density in the metro area, which means there's more choices. They might be closer to your home, that sort of thing. Plus, in addition to this information that's here on the chart about the providers that are available, over half of physicians in rural New York are over the age of 65. And that means that unless we see a significant number of new physicians filling in the workforce, we can expect the number of rural physicians to continue to decrease as the physician workforce ages. So that will just increase that disparity here in New York. Okay, next slide. So this shows some of the health professional shortage areas. So this is a federal designation. You can see that 10% of physicians in America practice in rural areas, but they are serving 25% of the population. Next slide. All right, and here's just one example of the combination of access and sort of quality of care. So the difficulties in access here are impacting the actual quality of the care that's provided. So this study said that Medicare patients experiencing a heart attack and treated in rural hospitals were less likely to receive the recommended treatments and had a higher, so that's sort of the care delivery issue, and then had a higher adjusted 30-day post-heart attack death rate from all causes than those in urban hospitals. So that's sort of your health outcome that's coming out of this situation. So as we think about this data, we want to be thinking about how these factors and these realities that people are facing are going to influence the way they see the provision of care in their communities. Okay, next slide. Okay, so this is a graphic about response time for emergency medical services. These times are national averages, and we see that the rural areas on average wait at about twice as long for emergency medical response as compared to urban counterparts. Actual wait times are probably much higher in many rural areas, and we know that from our own rural Broome County area, where drive times to the nearest hospital exceed 45 minutes in the more rural areas of the county. And long distances are a key barrier for many people living in rural areas. The average trips for medical and dental services are about 9 miles longer than in rural regions, or 9 miles longer in rural regions. And again, that's an average. So some parts of the country, and even here in New York State, we see much, much longer distances than that. Next slide. Okay. So this is sort of my last little chunk of data here. So this is about the expected and excess deaths due to unintentional injuries. And when you look at rural disparities and when you look at the literature around rural disparities, injury is one that comes up a lot. So unintentional injuries that sort of go into this statistic include things like poisoning, car accidents, drowning, and falls. So unintentional injury is the 5th leading overall cause of death in the United States, and the leading cause of death for people under the age of 35. We have more on the next slide for one contributing factor under sort of the motor vehicle accidents heading. So safety, rural road safety and infrastructure. Safety is a key consideration for building, implementing, and maintaining transportation systems and programs in rural areas. So several safety concerns are more pronounced in small towns and rural communities. So according to the Insurance Institute for Highway Safety, 40% of motor vehicle accidents occur on rural roads. And while this has been reducing over time from approximately 55% in 2012 The Federal Highway Administration estimates that 40% of the roads in rural areas are inadequate for current travel levels, and that 50% of bridges over 20 feet long are considered structurally deficient. We know that rural industries have more heavy equipment and machinery usage, which can also contribute to those higher statistics in unintentional injury. And data shows that public transportation can actually reduce the number of traffic fatalities. However, more and more rural communities are seeing the loss of funding and infrastructure to support public transportation programs because they just don't have the financial and the tax base to support it. So as we now head into our discussion of rural culture, be thinking about how all the data we reviewed might look and might be received and digested from the perspective of clients, as well as many of us as providers. So from the client perspective, how might these disparities, especially in access to care, influence the way we see the people who are trying to provide us those services? And then from the provider perspective, as someone who might be bringing that service to people living in a rural community, does this data provide you with enough information to really know that population? And what preconceived notions or bias or mental models might that information contribute to about the people you are serving? So I'm going to hand it back over to Mary to talk about some of the specifics of rural culture.
Thanks, Emma. So, as I mentioned before, you know, a lot of that data can be a little bleak, right? When we look at it, and you know, and I think Emma mentioned this, but also recognizing that some of that data is a few years old. But in developing this, and in kind of always looking to update the data, and making sure that we're sharing relevant information. What we're seeing is that even though the numbers might adjust a little bit, the distribution still looks very similar. But it can be a little bit of a bummer, right? Because it really does in some ways paint a bleak picture. So we like to make sure that we are also talking about rural cultural strengths. And if many of you are people who are from rural areas, or maybe you grew up there, or you live there now, or your purpose and your position and your profession is to serve rural areas, I think a lot of what we'll talk about will sort of strike you, but I think the strengths are important to remember as well. So this quote that you see here on the slide by Dr. Deborah Mosier came from the literature that we use to help guide the development of this presentation, especially this part of it when we're talking about rural culture specifically. And I won't read it to you. I'll give you just a moment to read it over, but it's something that I've always thought, as a person who was born and raised in a rural, very, very small rural community, it's always stood out to me as being very, very accurate. Okay, so we have another video. So I'm going to, once again, very smoothly switch screens. So this video is a real life example of exactly what that quote that you just read described. This is actually a community not far from us here in New York. It's about an hour and a half from here. And this is a project that took place a few years ago. It was local. It was funded by a local community foundation in our region. And I think it's such a great illustration, like I said, of what we just read about in that quote.
Communities don't exist to be so they can serve me as an individual. I need to lend a hand, and if everybody lends a little bit of a hand, things get done. And this is living proof that that can in fact happen.
So we got the schoolhouse in 1938.
The schoolhouse was in a state of disrepair.
The schoolhouse was falling apart.
There was a big gaping hole in the back of the schoolhouse where a tree had fallen, and if we didn't do something quick, we were going to lose it.
Yeah, I just couldn't bear to think that bell's going to go down and no one's going to do anything about it, you know.
The community had a strong desire to keep it in the community.
I just got on the phone and started calling different people up, and here we are.
We had already been going about 2-3 years over at the schoolhouse before we acquired the community hall. We had heard that it was purchased by somebody on the internet.
He said, if you can do the same thing to that hall you've done to that schoolhouse, your community, I'm going to give it to you.
I almost fell off my feet right then.
It was in pretty rough shape. It was a shell of a building. It had not been touched for decades.
Clarence and me felt that we could do it. Started working at it and got cleanup committees. And
it's a community project. Everybody that's interested and helps out.
Everybody pitched in and helped where they could and how they could.
anyone in the city, they would always say to us, well, what do you do out there in the country? To us, the hall was it.
It holds deep, deep value to the individuals here.
It was a kind of a meeting place for everyone.
We had more fun in this hall than you can imagine.
There were dances, round and square.
We put on many plays here, and there were a lot of people in the area that cooperated.
It was just so beautiful.
This is just wonderful, the way it's getting remodeled and reset.
A lot's been done with very little.
When times get rough, people help each other.
I think it's important because it's an anchor here in Altai. This and the schoolhouse, of course, and the church. Those three things have really kept this place glued together.
So the vision is to pass that on to the younger generation, that they'll see the value in getting to know the folks in your community, working together. That's what built these communities to start with.
What's holding them together is the prospect of going back to having dinners and dances and whatever here at this building. This is an outstanding spot.
It is something special. I'm hoping that those who see this will be inspired to say that we could do the same thing too.
There are communities like this all over the place where people grow up and then they leave. Mm-hmm. But even in Altai, they're seeing sort of the small surge of people coming back to their community. So you have these older members wanting to make a place for some of the younger ones coming back and wanting to call Altai their home too. It's just a wonderful thing to see.
A place like Altai that is so small, it's just so full of really interesting people. It's such a perfect illustration of what our relationship as the Community Foundation is to the people that we serve.
Just the love and the passion that they had for their small community, and that they've done all of this under the radar.
Yes.
And that's why the connection to the Good Works Project just makes so much sense, to be able to lift that up and show the greater community what this small group of citizens are doing.
It's a story we can tell for generations here at the Community Foundation. I think it really illustrates what we can do when the community calls us, and we love when the phone rings.
Is that the correct view, Liz and Emma?
Yes.
Okay, great, thank you. Okay, so as we were developing this training, we looked at a lot of research that had been done in rural communities and about rural communities. And the first thing that we learned is that there was not a lot. There's not been a lot of work done on rural culture. So often when you hear cultural competency, it sort of comes and goes as one of those buzz phrases. What is being referenced is, working with people from different racial and ethnic backgrounds, or maybe working with people for whom English is not their first language, but there's really not about there's not a lot out there about rural culture. And so as we were going through and looking at what does exist, we were seeing a lot of themes. And one of the themes that we're seeing were these sort of core characteristics of rural people and rural communities that were sort of rising to the surface from all of this different research. And really the research came from all over the country. The limited research that exists came from all over the country. There's been some really great work done at Cornell University, which is not far from us here in New York. There's also some really great research that has come out of like the Midwest and that sort of middle part of the country, which, as I mentioned, rural looks very different in some of those areas. But like I said, these are the sort of core characteristics that rose up as we were looking. So we're going to do an activity, as long as our whiteboard function works, we're going to do an activity where we're going to go through each of these core characteristics. And I just want to open up a discussion for anyone who's willing and able to unmute yourself. And I just want to have a discussion about what you think of in terms of traditional attitudes. And I think, you know, the main thing would be focusing in on what's a strength of traditional attitudes in rural communities and what might be something that could cause challenges for folks in those traditional attitudes. And I see folks on the screen figuring out how to use that annotate feature. So if you're not sure and you go over to the left side and you click the T, where it says, which is for text, you will then be able to move your cursor and start typing, and it should type whatever you want. So we'll do this as sort of a brainstorm activity. So when you think of traditional attitudes in rural communities, what comes to mind?
I'm going to ask a question. Is it traditional attitudes in the rural communities or about rural communities?
I think in them.
Okay.
That's a good question. Oh, I see people getting creative. I see we can get things done, community oriented. Depending on each other. Feeling like they don't need help. Privacy. Mm-hmm. I see pride. We take care of our own. Self-dependent, close-knit community, keeping things simple. Resourceful. Family oriented. It's like little beetles moving around the screen. Keeping things simple. Family is of utmost importance. Dependability, grit. That's a great word. We call that rural resilience here. Care about their neighbor, right? Okay, so would anyone like, oh, I see family, independence, live near their family. Yep, skeptical, stubborn. Okay, so let's open it up for a brief discussion about some of these. And again, anyone can unmute themselves and share. When you look at the screen, or maybe if it's something that you put on here yourself, what do you view as a strength? And elaborate on that a little bit. Let me ask it this way. So I see independent. Can anyone share their thoughts on how independence can be both a strength and a challenge?
It's Lori from the Institute for Human Services. That was not one of my words that I thought of, but I think it's an amazing word to explain our rural community. And I think that it could be a positive because we are independent in the sense that we get stuff done on our own. A lot of other words can come into that. So we're resourceful. We look at our neighbors, and independent also means that they don't want to ask for help. So even though they may need assistance with food insecurities, they might not go to the local VSS or the local food pantry to accept that because it's not the small town way to do it.
Mm-hmm. Yeah, absolutely. And that's actually a really good segue into our sort of next characteristic. So let's take a look at, and hopefully it changes. You should all be able to now see a blank screen that says isolation on it. So do the same thing. What comes to mind for you in terms of isolation? So we heard Lori say in regard to independence, that we can sometimes wind up sort of closed off to asking for help. But what do you think about isolation? Because there can be some, even though, I'm sorry, you can still see traditional attitudes. Emma, don't know why it didn't switch.
I'm seeing isolation. Are other people seeing that? Or can you on your own click on in the far right, bottom right corner of the Zoom screen, click on pages, and there's 5 of them. You see Sam Carroll's there. All right, people are getting there. Thanks. Okay. This is the first time I've done Zoom whiteboards, so I am learning and hopefully functioning.
Okay, so as people are sort of brainstorming this and thinking about isolation, for some folks, isolation is not a negative thing, even though it sounds like a negative word to us. So can anyone think of any ways that isolation might be a strength for folks in a rural community? Why might rural folks view isolation as a positive thing? And anyone can speak up. I'm seeing loneliness, separation, again, prideful, protective.
Mary, it's Johnny Kusick with Open Plains Transit. I think I live in a very frontier part of Nebraska, and we serve a lot of the communities in Western Nebraska, period, with intercity and local services. So, but I think, we see isolation firsthand every day. So I think, a lot of times what's positive about that is because it does force people to be creative and to become self-sufficient on a lot of different levels and kind of have that we can get it done sort of attitude. But at the same time, I know, especially with the pandemic, that we went through and we see it not just in our elderly and the very young, but a lot of rural isolation and loneliness that has definitely had an effect on social determinants of health, on people's health outcomes, period, and just really trying to use transportation as a means to try to pull them out of that. And I say that because we just started services in Valentine, Nebraska, which had never had any public transportation before. In history, and just see how some people have changed just being able to get out and go to a senior center, or to be able to go to the grocery store, or to just be able to do what they want, and to see that transformation in maybe just a couple of weeks or a couple of months time with individuals. So I think it could be a positive and a negative.
Yeah, absolutely. Certainly there are folks who thrive in isolation, right? People just prefer it that way and they do just fine. But I think your point, Johnny, illustrates that it can actually also create a lot of challenges for people. And, you know, something I always like to point out when we talk about isolation is that it's not always geographic, right? And so when we're working with people, it's important that we not assume that even though someone may have people living or you know, very close to them, whether it's close neighbors or family members, they could still be very isolated. So again, it's also important to remember that that it's not always, isolation is not always physical. It's not always geographic.
I just wanted to mention, this is Gail from Schuyler County, New York, is that we have a lot of older folks who are in congregate housing, and that congregate housing tends to be in our, you know, more our epicenter communities, which are all still very small and very rural. And so there's this assumption that because the people that live there are in congregate housing, that they are not isolated. But I can share that from the actual outreach experience and collecting those stories and hearing from folks that they are some of the most isolated because they simply can't easily get out of the congregate setting. So even though they might be physically close to a lot of things or to other people, they're not necessarily close to their people. They might be, you know, like 2 counties away from where they actually grew up in a very tight-knit rural community. So I think that, again, those assumptions that get made are more often incorrect than correct. And it was one of the reasons I got excited about seeing this training today. I thought, well, this will be good. Where this is a constant thing that I face up to, and even in my own organization and in the partner human service organizations that have, again, if you are not out boots on the ground speaking with people or listening or just being on the great listening tour, you do have a very different lens and definitely just sets of eyes that look in the back of your own head. So thank you. But
yeah, thank you for sharing that, Gail. Absolutely, and that's a great example of people living in congregate locations. And I like what I just noted on the screen that someone put, some people don't feel isolated. And again, that's that really important part about getting to know the people that we're working with, right? And not making those assumptions. And Gail, I'll just say, as I'm going to move on to rural socioeconomics, but we are neighbors. I actually grew up in Yates County. So it's nice to see you here. And I know what you speak of with the rurality there. Okay, so rural socioeconomics, hopefully y'all can see that new whiteboard page. So we talked about this just a little bit, I think, or maybe we removed it, but rural socioeconomics has a lot of strengths and a lot of challenges. Just to throw out a couple of examples as you're thinking about what those might be, there are less job opportunities, to put it very simply, in rural communities. And often for those job opportunities that are there, they're lower paying jobs. Unemployment rates are higher in rural communities typically. And in rural communities, you see more people working in small businesses, working in family-owned businesses. You see lower rates of people with health insurance and people who are underinsured. And so those can all be challenges. A benefit of the socioeconomics in rural communities is that you often have a very dedicated business community. A lot of times those businesses are owned by local people. And so you do have an opportunity for your money to stay in the community and to support your neighbors and to support the other folks in your area. But again, it can be challenging to maintain a business in a small area. What else? Anything else that people can think of about rural socioeconomics? Pros and cons?
Again, I would say that the assumption part is often dangerous, so we have a lot of beautiful areas in Schuyler County, and so you can have folks who, when you talk about the socioeconomic, they have chosen to live in that beautiful area, and they have lots of resources that keep them, you know, really on a great place for social determinants of health. And then you can have in that same area in close proximity, extraordinarily different situations. And one example I can think of is, there's lots of them, but one that I see every single day because I live in the northern part of Hector, almost by the Seneca County border. On the east side of Seneca Lake, it's as simple as if you drive down a lake road to the lake versus if you drive up the hill to deep, it could be deep into the national forest where some people have their homes and choose to live, to anywhere out in the middle of nowhere. It's completely different. It's so, and everybody says it's rural, all the same.
Yeah. Yeah, absolutely. And I think, and again, that's a great example. And not to like, you know, intrude on everybody's time talking about mine and Gail's hometown, but I mentioned before that culture within the culture, right? So in that part of New York State, you have a lot of poverty. You also have a lot of people who own vineyards and wineries. You also have a lot of agriculture, a lot of people who are thriving and doing very well with dairy farms and whatnot. And you also have people who come in from outside of the area to buy very beautiful, very large, very expensive houses on the Finger Lakes. And so there is a mix. And again, as Gail pointed out, to an outsider's eye, and Mennonite populations, there are pretty large Mennonite populations in that area too. So for an outsider's eye, you might look and say, well, this is a rural area, everybody's rural, this is applicable, but it's absolutely not. There are countless cultures within that one specific culture.
Yeah, can I say, I mean, I think I know that, you know, we have communities now that know they need public transportation options, especially for the elderly population a lot, but at the same time know that they will have trouble passing like gross receipts taxes to help fund participation in rural metro districts. So that's something that we're experiencing.
Yeah, absolutely. Where we are, the rural, even in Broome County, which is the sort of population center in our region, we have public transportation in the population center, but the population center itself is very small, and the rural part of the county that surrounds that is very large. But even the public transportation that's in the population center doesn't go out to the rural communities, even though it's all part of the same county. So it creates a lot of challenges as well. I want to keep going because I've got one eye on our time. So our next characteristic is work belief and health. And what this really refers to is an idea, and this is not exclusive to rural cultures, I should say. And in fact, all of these characteristics have some, do carry over into other cultures as well. But work belief and health really refers to this sort of philosophy of we seek out healthcare when we're in an emergency situation, right? So I've been not feeling well. Now it's turned into I have a fever and I'm having a hard time getting out of bed. I guess I should go to the doctor. And also the sort of like the thing that goes right alongside of that is this idea that if we do get sick or we do get injured and we go and we get the care that we need, we don't like to allow ourselves a lot of recovery time, right? So I was sick, I got my medicine, I should be able to get right back to work, to school, to taking care of my family, all the things that I need to do. I broke my wrist, I got it set, I got a cast on it, I should be able to get right back to work. I lost a close member of my family. we did the things we needed to do. We had the funeral, all of the other things. I should be able to get right back to work without allowing myself that sort of recovery time. And so, work belief and health, again, if, you're welcome. I don't know if you all can see this, hopefully you can. If there are other sort of strengths and challenges to this, I know that, like I mentioned earlier, we call it rural resilience here, but this idea of the work ethic, right? That tends to be very, very strong in rural communities for a lot of folks. But at the same time, if our work ethic is so strong that we're not taking the time to take care of ourselves, then the work ethic is not going to mean very much to us in the long run.
Sorry,
And
I stepped away for a minute, but you may have already spoken of this, but I was wondering about access to internet, and whether the areas with better broadband internet access, and also where people have good access or cell phone minutes that allow them to actually use broadband, whether telehealth has improved health outcomes in those areas, whether you can see a difference, because that would seem like something that you might be able to measure pretty well.
Mm-hmm. Yeah, and it does look like Emma had responded to your comment in the chat, Holly. We did see that pop up.
Oh yeah, great. Thank you so much. Yeah, that was an interesting source of discussion.
Yeah. It'll be very interesting as we continue to move out of COVID, hopefully across, knock on wood. The data that comes out about telehealth and what happens with the waivers that were put into place to make telehealth and telemedicine more accessible to people during COVID. It'll be very interesting to see what comes out of that. Anecdotally, I hear from our clinical partners in particular that they did see a big uptick in people accessing health services, and in particular behavioral health services, who had never accessed it before. And so we definitely saw that sort of anecdotally. I have not looked at the data recently, but I am sure that something interesting will be coming out about that soon.
I guess in one way it's good to advocate for. So, I know there's been a big push to put broadband up in the Newfield area, and I'm sure it is having some impact. It'd be great to study that and see whether it's applicable to other areas as well, and whether people want it.
Mm-hmm. Yeah, absolutely. I learned a lot about dark fiber during COVID, which sounds very ominous to me. Yeah, okay, so I see, people sort of brainstorming on the slide, but yeah, farming is becoming a high suicide field. That's a whole other presentation. Absolutely, there's a lot to say about that. And yeah, definitely a lot of challenges, not enough staff to be able to cross-train with someone as sick and out. And that has also affected the workforce in terms of turnover and being able to fill positions. There are not enough people. Okay, and then I'm just going to move to the last one because we are getting close to time. So the last sort of concept, or the core characteristic, is this idea of insider, outsider, old timer, newcomer. This is the idea that people who are from the community are the people who have the historical knowledge about the community. They are the pillars of the community. They are the people that you go to when you need information. And they are the people whose word is sort of accepted. Folks who move into the community, and sometimes regardless of how long they've been there, if people know that they're not originally from there, they're sort of often seen as less informed, and their word and their opinions are sometimes seen as less valid. I have a colleague who shares, and I always share this story because I think it's so remarkable, but she's actually retired now, to give you an idea of how long ago this was, but she went to, she's from Long Island. She moved up to Delaware County, which Emma mentioned before is very large and very rural. And went to school there and met a man who was from a local small town in Delaware County, married him, had children, raised her kids there. The children went to the same school district as the husband did, all through their lives. She's now in her 60s and she's still seen as an outsider in that community, because all of the folks who live there in this small town know that she didn't come from there. And that is something that happens pretty frequently if you sort of marry into the community or you move in as an adult. That can happen pretty frequently. This is how we've always done it. Yes. Communities can be cliquey. They sure can. Newcomers don't know the history. I found growing up in a very, very small town, if people don't know your story, they'll come up with it on their own. And then someone will tell you what your own story is. Yeah, absolutely. So we are kind of at time. We do have one more activity, but we're not really going to have time for that because I don't want to keep everybody over. So I think what we can do afterwards, Liz, is I can send a document to you that you can share with everyone. It's really just sort of a skit that we like to do that really illustrates all of these core characteristics, and there's some really good examples in there, but I'm happy to share that with everyone afterwards so that we don't run way over time today. It's a bummer because it's a really fun activity, but I will share it. Okay, so Liz, I need to share my screen to get back to the slides, right? Okay.
Yeah, I just closed the whiteboard so we can go back to the slides. And, I'm sure we can hang on if anybody wants to, if they have questions and you want to hang on longer. I can stay, Mary and Emma can probably stay a little bit longer, but I think sharing the resource for those who do have to leave would be great.
Thank you. Yeah, I think Emma has to jump off. We have another meeting at 3:30 that we kept trying to move, and the person didn't respond to us. And so we're like, is she going to be there? So I think Emma's going to jump off to join that meeting, but I can definitely stick around. Okay, so this goes with the activity. So we will skip past that. And I would like to just sort of take our last few minutes to just have a brief conversation about your own cultural competence, right? So if anybody is willing to share, how do you think you're doing? How do you think your program that you work within or your sector, how do you think it's doing? And what do you think you need? What resources can be helpful with moving things along?
I'm dying to see that exercise to see if that will help, since as transportation, I'm the linkage to all of the human service providers. And so my goal in life before I die is to tear down the silos and have that universal look, so that, for really serving community, it's thought of in a broader way. And it stops looking at the, hey, you got your club card or your key card, perspective. And so I even have to say, for the organization I work for, which is the contracted provider for our public transit and mobility management, even in that organization, sadly, I think we suffer a lot from cultural incompetence.
Mm-hmm.
Or expert, I like to call it sometimes expertitis, but we're the experts on this.
Right.
No, you're not.
And-
The end
right.
users are.
Right, exactly. And that's what we, those of us, now I'll speak about myself, came into this, the human services sector, which is what I've worked in for 20 something years. And, we were sort of taught like everybody that walks through your door gets the same, right? But our knowledge of social determinants of health and health disparities and see it as you just mentioned, Gail, seeing the people that we serve as the experts in their own situations was not what we were trained. That's not the way we were trained in the beginning. And so, when we know better, we do better. My goal is like yours, Gail. Like by the time I'm ready to retire and move on, we're in a much better place. But this is always a work in progress, and that's why we talk about it from this perspective of, building that culturally competent organization. It's not simple. It's not something, because it's not intuitive, right? And it's not something that we were sort of taught from the beginning. And so it's really important to have sort of a guide to be able to go back and check yourself and to have that self-awareness to be able to say, are we really doing everything that we can, or do we need to make some adjustments? And change is hard. So it's definitely a sprint, a marathon, not a sprint, right?
I see that increased sensitivity to alienating behaviors. And since a lot of our communication happens through, through language, through words, I might have collected for myself these things like uh-oh, watch out if you said that, or if somebody else is saying that, address that. And I don't know any other way to increase that sensitivity to alienating behaviors, other than, listen first, listen more, talk less, but also when you do speak or you do enter into the dialogue, just really watching for those sort of trigger, we know we're in the weeds. For me, it's any sentence that begins with, if people only, and you can put anything you want after it, which means all kinds of things, like you already know what the solution is, or it could mean that you have absolutely no clue what that person's real situation is, or what they need. This is part of our everyday dialogue, and I'm always looking for ways to help myself with it. And then if I learn, then I model, and other people, fully also walk down that different path. I will share with this group that I know the National Center for Mobility Management, the RFP, the submissions closed on August 4th, but we submitted here for Schuyler County, but with regional reach as a definite must-have for their innovation, design innovation challenge. And I read that RFP a number of times and then said, why does this sound so familiar? And realized it was my voice and other mobility managers' voices echoing from the most recent conference, where we talked constantly about, but are we listening? The end user is anybody that's not you. And we're not listening to end users. We're not even seeking them out. We love to throw the best practices around like they're, some super magical unicorn dust, but they might not have any relationship to the folks that we're there to support or serve, or the changing landscape. And so we submitted for that grant, which is all go out and, interview, meet people where they are, interview them, observe, write it all down, think about it.
Yeah.
Before you say, well, if we just did this, it'll all be fine.
Yeah, no, I love that. That's such a great, I'm a big proponent of focus groups.
Yeah, this is a really big one.
Yeah, and I find that when you give people the opportunity to tell you what you're doing wrong and how you can improve it, they will take it. They will tell you. You just have to ask them. And you know, one of the things that we didn't spend a lot of time talking about it today, but there's actually a longer version of this training, but it would have kept you all here for about 3 hours. So we opted for the shorter version. We talk about the importance of building trust and identifying who key people in rural communities are, because often when you go through those key people, or you go through those insiders or the old timers, that's really key to building trust, and doing exactly what you're describing, Gail, with finding ways to get out into the communities and observe people and talk to people and interview people, is really key, because that shows that you truly are there to make improvements and not just there to drop your program and run, which is what people kind of get used to. So yeah, I did just send you my email address, Gail, if you want to follow up with me. I'd love to hear more about what you're working on.
Awesome. I know I have to hop off, and I want to leave just one last thought. I, like a lot of folks who work anywhere in human services or health and human services, we are really under a lot of pressure to not put our business card out there that has our direct information or how you reach us or whatever. And most people, quite frankly, find my office through our transportation link line. But even again, within my organization, and then my fellow organizations have the same thing, I say repeatedly, my first opportunity to build trust with somebody that's maybe never met me before, it might be at a tabling event or an outreach, or somebody introduced me to something, is to hand over my business card, because now I've said to them, hi, this is what my name is. You don't have to write it down or save it. This is how you call me directly. You can call me, because that's not an invitation that gets extended. And I understand all the protection and arm's length things, but if you want that trust and you want that, and you really want that relationship, so what it is that you should be working on and doing, I don't know a better way to do that than to simply hand that business card over and say, I really do mean this. It was so nice to meet you today. And then I'm quietly somewhere in the background making a note of what their name was and where we were, because it will make all the difference.
Yep.
For the real stuff.
Absolutely. Well, thank you. Thank you for being here and your contributions today, Gail.
Appreciated the opportunity. Thank you.
Mary, it's Johnny Kusick from Nebraska again. Hey, I just wanted to share that I think what Gail's doing is exactly what I think we all need to be doing in communities. But I did want to share real quick, because I know we're past time, is in our community, actually, I should say in the Panhandle region of Nebraska, we actually brought in Bridges Out of Poverty. I don't know if anyone's ever heard about it. It's a compassion coalition. And what it is, it's a framework of understanding poverty and the hidden rules of economic classes. And they actually use the framework to develop programs and strategies that improve relationships, like at the frontline level, improve outcomes at the organizational level, and improve systems at the community level. And it is such, I think that if anyone who is in a leadership role or as a community stakeholder goes through the training, we felt so strongly about it that we actually raised money to, in our community in Alliance, Nebraska, to be able to bring a Train the Trainer program for Bridges Out of Poverty to the Panhandle region of Nebraska, because it really gives you that insight of understanding individuals at their level and understanding, why there are why people react or act certain ways due to social, economic class. But it was just remarkable about what was learned and taken out of this program that I almost just cannot stress it enough. It is probably one of the most worthwhile trainings that I've been in my professional career, that it really gives you a totally different insight. And you can just purchase the books online or whatnot, but really helps, I think, with really getting to the root causes of why people act the way that they do, whether it's social status, economics, whatever the case may be, and to also help share those hidden rules of how people get ahead. Because if you don't know, you don't know, and so, how do you go about being able to make that change, and empowering people to make change for themselves? And so I just really wanted to share that in case anybody, really wanted to look into that, because it is, I think, very worthwhile when it comes to spending your time on something, whether you do it independently or do go through the program. So.
And Johnny, that was Bridges Out of Poverty.
It's called Bridges Out of Poverty. And the gentleman that we had that came out to Nebraska, I can't think of his name right off the top of my head, but it's really through the Compassion Coalition. But you can just Google it. I mean, you will find all sorts of information. You can find trainers that can come. In fact, we had him here twice in Alliance. Well, I should say once in the region and once in my hometown. But boy, it really does change your outlook on a lot of different things if you really kind of work the program and work the steps in. And it's just interesting. I don't think there was a person that was bored for a moment. The presenter that we had was great. So like I said, we raised the funds, worked with our United Way to actually bring a train the trainer program to Western Nebraska. So people that were interested, so we would have trainers here more locally, just because we have such diverse populations and whatnot. But just wanted to share that. Thank you.
Thank you, Johnny. And I have not participated in that program, but I've been hearing about it for years. And I think everybody who talks about it says exactly what you said, that they can't recommend it enough. Okay, so that's me. So we do have a post evaluation. Again, I know a lot of people had to jump off, so we'll send this. I will pull together a packet and get it to Liz this week with information to share with everybody that was here today. And there is another QR code. This is a different QR code for a post evaluation. So if you completed the pre and you wouldn't mind completing the post, just a hint, the questions look very, very similar, but that really just helps us improve our program. So if you would not mind doing that, that would be very helpful. I will also include this post evaluation code in the packet that I send out. And then I think that Liz just had a couple of wrap up things as well.
Sure. Thanks so much, Mary. So, there were a couple of questions in the chat. We will post the PowerPoint and the recording of the training on the webinars page of our website, probably by tomorrow, but we say within a week, just in case. But we will send an email out with a follow-up. There will also be another survey that pops up when you close Zoom. So I know it's a lot of surveys, but if you have any feedback you want to share with us or other trainings and or other resources you're interested on this subject, that would be a great place to share that with us. Some additional upcoming events. So tomorrow there is a Learn About Tackle. We do these twice a year. Tackle is the Transportation Technical Assistance Coordination Library. This is shared with our other FTA technical assistance centers, and it contains all sorts of information about transportation coordination. And so one of the resources from the Shared Use Mobility Center will be highlighted tomorrow. We have a fun book group, and that's next week on the 22nd. And the book is I Was Told It Would Get Easier. So all these books have some sort of bus or transportation related to it. Later in the week is a rural INTD webinar, and that is about the Integrated National Transit Database System, which you can use to compare your system or all the transit systems in your state. And there are various performance measures and ways that you can look at, analyze the NTD data that is collected. Then on August 30th, we have a transit manager peer roundtable, and this will have a training focus. So we have like 5 topics about within the general topic of training that we'll be discussing, and we'll have some of our review board members will be kind of kicking off discussion on some of those questions. And then we have later, so in late September, we will have a second of these trainings. So this will be, again, Mary and Emma presenting a training that they've developed and that they use in their organization. And this is on client self-advocacy. So I'll put the link in the chat, and it's also on our webinars page now. And then finally, we're trying a new format of, this is called a LinkedIn Learn Along about communication. And so check that out. My colleague Kara is going to be hosting that, and we hope you'll join us for that. Next slide, Mary, just a couple more. Our conference is coming up quickly in December, and we're super close to having registration launched, so probably within the next few days. And we are also will have an agenda posted this week, a draft agenda. We have various awards and a student poster contest and other things that are going on. You can book your hotel, and we really hope to see all of you there. And last slide is just our contact information. So I just really want to thank all of you for coming today and staying a little bit longer. And, you know, if you want more of these, if you'd be willing to stay longer, you know, again, let us know. And Mary and Emma, thank you so much for your wonderful presentation and sharing your knowledge with us today. And for those of you who participated, I learned something new, and I hope you all did too. So thank you so much.
Thank you all so much for your time today. It was great working with you.
Thank you, and hope to see you in September at our next training. Let me, as I said I would, I'll put that in the chat, and then, but as I mentioned earlier, if anyone ever has questions, you know, reach out to us at National RTAP. And thank you again, Mary and Emma, and everybody. Have a great rest of your day.
Thank you.
Thank you.
Bye.